All right, so this obviously is a problem that we're all very familiar with. This is a very common issue. There's about 69 million people annually around the world who suffer from traumatic brain injuries, and 95% or anywhere from 80 to 95% are in the mild range. This prevalence is higher in men as compared to women, about 4 to 7% in males as opposed to 2 to 4% in women. You can kind of imagine why that might be. There are certain activities or occupations that increase the risk for brain injuries. The number of or the prevalence of post-traumatic headache really ranges in the literature. It can be anywhere from 29 to 58% in the following 6 to 12 months. And in children, that number is similar and around 43 to 60%, depending on the studies. Interestingly, there seems to be a somewhat inverse relationship between the prevalence of post-traumatic headache, depending on the severity of the traumatic brain injury, with there being a slightly lower prevalence of about 33% in moderate to severe traumatic brain injury, as opposed to 58% in mild traumatic brain injury. Some of the discrepancy may be due to underreporting. A lot of these studies come from studies of patients who actually present to medical facilities, whether that be a physician or the emergency room. And so we may not be capturing all of those patients who actually suffer from traumatic brain injury and post-traumatic headache. And then often, or another issue may be that they get an incorrect diagnosis, particularly if they have a history of headache. They may be considered a migraine or chronic tension type headache rather than post-traumatic headache. And so the pathophysiology of post-traumatic headache is multifaceted and very interesting. And there are a lot of crossover between that and migraine, but there are still some very distinct characteristics. So interestingly, there can be impaired descending pain modulation. This leads to decrease in inhibitory projections to the trigeminocervical complex, leading to increase in pain sensitivity. There are neurometabolic changes such as increase in lactate. Mechanical trauma can cause unregulated influx of ions, leads to energy depletion and oxidative stress in the cells. There's a decrease in glucose metabolism and a cascade of neuroinflammatory events. Axonal damage also arises from neurofilament collapse and microtubule disassembly. The neuroinflammation can include activation of glial cells. There can be increase in production of pro-inflammatory mediators, which then cause neuronal and vascular damage and leakage of the blood-brain barrier. Cortical spreading depression is something that is seen both in post-traumatic headache as well as migraine often. This leads to release of pro-inflammatory molecules, a decrease in cerebral blood flow, and release of calcitonin gene-related peptide, which is implicated in the trigeminal vascular pain transmission pathway. There's trigeminal system activation, activation of trigeminal nerves, either from peripheral nerves or from stimulation of the meninges and the dura. Again, this is implicated in migraine and other primary headache disorders and can be seen in post-traumatic headache. TBI itself can lead to secondary cascade of events, such as decreased cerebral blood flow, vessel damage, axonal shearing, and a cascade of metabolic and cellular excitotoxic and inflammatory changes that can promote the development of post-traumatic headache. Patients that have post-traumatic headache and no prior history of migraines can also still have hypersensitivity to calcitonin gene-related peptide, which poses an interesting potential therapeutic target. There are also structural and functional differences that have been found in post-traumatic headache. For example, in Chong et al., they found that there were differences in fiber tract profiles between those with migraine and persistent post-traumatic headache in the bilateral anterior thalamic radiations, the cingulum, the longitudinal fasciculi, and uncinate fasciculi. Another study showed decreased cortical thickness in the bifrontal and right parietal regions of the brain that was seen in persistent post-traumatic headache. In patients without pre-existing headaches and had traumatic injury, they had decreased anterior cingulate and dorsolateral prefrontal cortex gray matter density. And at 12 months, these findings resolved, but they showed increased gray matter density in the midbrain, thalami, and cerebellum following resolution, which may represent a response in terms of pain regulation. These are very important functional changes over time, which may be implicated in the pain pathways. There are several other areas that have been implicated, such as the left precuneus, the left caudal middle frontal lobe, the left superior frontal lobe, and right lateral orbital frontal lobes, and the right supramarginal gyrus. A lot of these areas do show resolution after about 12 months, with the last 3 being the only ones remaining. There can be also some functional changes, such as on EEG. Acutely after traumatic brain injury, there can be focal slowing, amplitude asymmetry in about 54% of cases, and absence of fast activity after TBI. And these usually resolve after a few weeks and return back to baseline. In terms of risk factors, there are several studies that have identified some risk factors, but obviously we don't know all of the risk factors for developing post-traumatic headache or persistent post-traumatic headache. Of the ones that have been most clearly delineated, female gender has been associated with increased risk of post-traumatic headache. Females are more likely to report headaches at 3 months post-injury, at about 57% women compared to 41% of men, and had a higher prevalence of post-concussive symptoms overall. Older age was associated with higher risk, severity of the injury at onset, and if it's mentioned here, blast mechanism. So in certain studies that looked at military personnel, if they had a blast mechanism versus a non-blast mechanism for their headaches, this was, along with loss of consciousness, more strongly associated with post-traumatic headaches, post-traumatic stress disorder, and depression. Loss of consciousness, so length of loss of consciousness, if you have a history of multiple TBIs, if you have vertigo, insomnia, and somatic pain at the time of the traumatic brain injury, this was also a risk factor. And also in one study, they showed craniofacial procedures such as craniotomy also seem to have a higher association with post-traumatic headache. The clinical characteristics can be quite varying, but for the most part seem to resemble either migraine-like headaches or tension-like headaches. And again, depending on the study, either migraine-like headache was a higher prevalence, or tension-type headache. So in one study, it was up to 97% had tension-type features, while another study showed about 49 to 53% had migraine-like features. Some of this might be explained by either description or what criteria was being used for this diagnosis. It also is a little bit confounding that about a quarter to a third of individuals may have more than one type of headache. So they may actually have both migraine-like and tension-like headache. Less often, they can have other phenotypes such as hemicrania continua-like headache, cluster-like headache, and sunk-like headache. They can have similar triggers to that of tension-type headaches or migraines, such as bright lights, stress and nervousness, lack of sleep. The headaches were described as could be bilateral localization, moderate to severe in intensity with a pulsating or pressing-like quality. That was according to one study. It could be associated with other symptoms such as fatigue, dizziness, vertigo, sleep disturbances, impaired cognitive functions, and impaired psychosocial functioning. Depression, anxiety were also comorbid with post-traumatic headache, particularly in military personnel. and headaches going on longer than 12 months were considered to be chronic headaches. So the diagnosis of post-traumatic headache is classified according to the International Classification of Headache Disorders, or the ICHD-3, and is defined as headache at post-head trauma within 7 days or after regaining consciousness. So if they were in a coma or they had lost consciousness for more than 1 day, after regaining that consciousness, and then they're able to report pain within 7 days of that. And then is not better accounted by another diagnosis, so they don't have any other secondary cause of headache. Acute post-traumatic headache may last up to 3 months. Beyond this, this is considered to be persistent post-traumatic headache. This also can be further delineated into headache attributed to mild TBI, which is associated with transient confusion, disorientation, impaired consciousness, short-term memory loss around the event of the trauma. 2 or more symptoms of mild TBI, such as nausea, vomiting, visual disturbances, dizziness or vertigo, gait imbalance, or impaired cognitive functions, versus moderate to severe TBI, which is loss of consciousness for greater than 30 minutes, post-traumatic amnesia or altered level of awareness for greater than 24 hours, a GCS of less than 13, or brain imaging suggestive of TBI, such as skull fracture, ICH, or contusion. In terms of treatment options, we're limited as far as what is known to be effective. Of course, we go back to the treatments that are used for primary headache syndromes, such as tension or migraine, and we tend to treat the headaches as according to the type of headache that it's more closely related to. So NSAIDs are a mainstay of treatment for acute headaches. There's one study by Friedman et al. Where they used IV ketorolac along with metoclopramide, and this is in an inpatient setting. They did it for up to 48 hours, and in those patients, about 63% showed significant improvement after 48 hours with sustained relief, and about 53% had no headache or rare headache a week after treatment. Tylenol can be used. Anti-epileptics have been looked at extensively, and tricyclic antidepressants. In one study, Cushman et al., this was a retrospective study in use of tricyclic antidepressants and gabapentin for concussion symptoms. They showed a significant decrease in headache and symptom scores compared to those who were not given any type of treatment at all, with short-term improvements in the gabapentin in terms of symptoms and more sustained improvement with the tricyclic antidepressants. Another study of Army soldiers by Erickson et al., they showed decrease in headache days from 17.1 to 14.5 a month on an average with the use of topiramate as compared to low-dose tricyclic antidepressants. They also looked at the use of triptans, which had a higher percentage of headache relief in 2 hours as compared to other abortives such as Tylenol or other NSAIDs. Looking at other potential therapies, CGRP antagonists obviously are paradigm shifting in the world of headache. Right now, most of the studies are only geared towards migraine headaches. There was an open label study that showed a 28% reduction in headache frequency with the use of erenumab for post-traumatic headache. And there are a few case reports and some retrospective studies that show onabotulinum toxin can be potentially effective. But again, there are no dedicated studies with the use of onabotulinum toxin, and as far as I understand, they don't have any in the works right now. I'm sure there are people who have used onabotulinum toxin for post-traumatic headaches, particularly those that resemble more closely to migraine type. Transcranial magnetic stimulation. There have been a couple pilot studies by Lung et al. And Stilling et al. Where they looked at this, and the Lung et all study, they showed that there was decrease in number of headache days as well as decrease in depressive symptoms. In the study with Stilling et al., they did a double-blind randomized sham control trial. They had some positive results, but it did not reach statistical significance. So that's something that's still ongoing. And then the use of peripheral nerve blocks, SPG blocks, or trigger point injections. Again, there are no very clear studies regarding this, even in the world of just regular headaches. But there are some studies that show that it could potentially be helpful. There was a retrospective study of children aged 10 to 17 who had greater occipital nerve tenderness. Occipital nerve block was performed, and 71% had resolution or complete resolution of headache following the procedure, and 26% reported cure of their headaches on follow-up. They did not, unfortunately, say how long after that was their follow-up. The study was a little confounded by they were about average of 70 days out from injury. Most had multiple TBIs, and 82% in the study had received metoclopramide prior to the procedure, and about 33% had shown some improvement at that point already. There was another retrospective study in 15 children that showed similar results. So potentially greater occipital nerve blocks might be something to use in the toolbox. So going from here, there's obviously a real need for research in the area of post-traumatic headaches. Again, clearly defining diagnostic criteria and then design for randomized controlled trials. We need more randomized controlled trials to test how soon should we be starting therapies, what type of acute and preventative therapies are superior, and then eventually developing evidence-based treatment guidelines, and going over what sort of risk factors will better predict transformation into either chronic, persistent or chronic post-traumatic headaches. And that's everything for you. These are my resources. Thank you for listening.
Thank you. Thank you, Dr. Sanguinetti. Does anybody have any questions for Dr. Sanguinetti?